Hello, good afternoon to everyone, and thank you for joining us for an interesting session today on delivery of healthcare in what we're calling the new normal. And a good morning, I should say, a very, very early morning to Dominic Henry, who's joined us from London this morning. So good morning to you, Dom. My name's Kenneth Corcoran. I'm the industry practice leader for Aon's practice in the Pacific. And I'm joined today by Mark Dopel, partner at Spark Helmore and adjunct Professor of Law at Notre Dame University, and Dominic Henry, who I mentioned, who I'll refer to Dom as Dom throughout, is joining us from London. Dom heads our healthcare practice out of our Global Broking Centre in London. So as I said, thank you for joining us today for our session on the challenges of delivering healthcare in what we're calling the new normal in a world that's essentially come to a standstill as a result of COVID-19. I think we've all watched the rapid spread of the virus, and today I saw that news agencies are reporting almost 51 million confirmed cases worldwide now. So, an incredible number. 560,000 new cases just yesterday, and 125,000 of those cases in France alone. So the numbers are really staggering. More than 1.2 people have now sadly lost their lives to this disease. Thankfully, in Australia, we've kept that number. I think yesterday it was 907. So I'm sure, as I did, all of you read today with interest the news coming out of Pfizer on the studies that they've been doing, some really encouraging results on the vaccine. So we'll continue to watch that with great interest. I think they were talking about 90% as a result for efficacy, and I think the government said they'd be happy with one in two. So very encouraging. Please feel free. You'll see at the bottom of the screen that you're looking at a small button. It is a question answer as it suggests, so please feel free to use that function throughout. We'll do the best. I'll do my best to get to all of the questions. Feel free to ask a question to either Mark, Dominic, or myself, and we'll do our best to get to all of them in the next 45 minutes. So with that, let me start the ball rolling. Perhaps a question to you, Dominic, just to make sure you're still awake in 4:30 in London. So just on turning to insurance and the insurance market for a moment, I'm interested to know your thoughts on the market response to COVID-19, particularly in respect to some of the coverage and exclusions and even deductibles that we're seeing insurers apply to that. And forgive me for a question in a few parts. I can remind you of what they are if you need me to. But have you seen the coverage and those things differ by territory? And also, given that you're heading our Global Broking Centre in London and looking after business coming in from 30, in fact, over 30 countries, I believe, do you see that differ by territory?
Great. Yeah. Thank you, Ken. And good afternoon, everyone listening in. It's a real pleasure to talk to you. It's a shame that I couldn't do it in person. I think I'd much prefer to be down in Australia sort of enjoying your summer than rather it being our cold winter. But as Ken said, we've all got to get used to this new normal. I guess I'm pleased to say on the whole, Ken, that the medical malpractice underwriting community have been pretty supportive of our healthcare client base during COVID-19. There's no doubt there was some real nervousness in the early days, where it's still yet to be seen sort of how healthcare systems across the globe would deal with this crisis. The eye for a large amount of time was firmly fixed on the US because of the way in which their health system is structured. It's almost entirely privatized, which means they were unable to mount any sort of joined up approach or response to the crisis in the way a lot of other countries were. And I think underwriters were looking at the US as potentially a benchmark for sort of worst case scenario and what could go wrong. There was a lot of talk around surge planning, potential rationing of care, which, again, I'm pleased to say really hasn't materialized in any countries that we're aware of. New York probably would have been the closest that we saw to hospitals getting close to maximum capacity. But even there, we haven't seen any claims as a result of people being denied care due to a lack of availability, a lack of available ICU beds. And I guess as the pandemic's evolved, I think so is the underwriting community's approach to it. As I said, there was certainly some nervousness in the early days, and we did see only one or two carriers, but we did see them come out with fairly punitive exclusions. And their view was that this was a risk that they didn't understand, couldn't yet manage, and as a result needed to exclude it until they understood it a bit better. I'm pleased to say that was only one or two, and as the virus has progressed, we've seen them take a much more nuanced approach. And I'll come to the territorial specifics in a second, but on the whole, unlike other lines of business, we aren't seeing medical malpractice underwriters put full blanket exclusions on their risks for now. As I said, I know this isn't the case in some other lines, and Ken, I know me and you have talked about sort of approaches on lines like property or general liability. I think the main takeaway, I guess, from the medical malpractice underwriting community is that they're happy to take a much more nuanced approach, and we've worked really hard with them to ensure that healthcare wasn't thrown in the same bucket as those other lines of business, because healthcare does have a frontline exposure in the way others don't. So you mentioned some territorial differences, and that has absolutely been a factor. Some countries just have definitely handled the epidemic better than others. And actually, I think probably when people look back, I think there's a couple of countries that will absolutely be held up as gold standards in their response to the COVID-19 epidemic. And I actually think Australia will probably be one of them in the way that you've handled it and preserved life and preserved your healthcare systems. On the opposite side of the fence, I mean, there's been some European countries, the UK probably included, who could have absolutely handled the crisis better. And going one further than that, there's also some specific types of risks, such as long-term care, which are basically uninsurable without a full COVID-19 exclusion. And we've seen that as a blanket approach from the market. And not to pick on them, but just because it's sort of front of mind for me at the moment, because we're trying to help them, is the Spanish public system is the same. They're a public system who buy commercial insurance. They're not state funded from an indemnity standpoint. And that as a risk is all but uninsurable without a COVID-19 exclusion, just because of the lack of control that they seem to on the virus. So I'm not saying that medical malpractice is free from its challenges. It's certainly not. But I guess the message is a generally positive one. And I hope that most of you all on the phone have actually had similar experiences as you work through your insurance renewals. There are certainly some factors that underwriters are looking at closely, which might impact your renewal outcome. But I'd say clients are certainly getting a fair hearing. And we're seeing, you picked on sort of deductibles and specific types of coverage restrictions. What we're seeing is that they're taking an appropriate response based on the perceived risk. So that might be having a slightly larger deductible for COVID-19 where there's a very small one in place, or saying we can't have an aggregated deductible when there is an aggregate in place, or just something as simple as a condition on the policy which says the client must adhere to all public health guidelines, and if you willfully disregard those guidelines, then your insurance won't respond, which I think in the general is reasonable. It's sort of behavior that I think we all would expect of a healthcare organization. And I think it's just kind of giving the underwriters that sleep easy, that they've got something contractual to fall on should they need it. But as I said, I think generally the message is a pretty positive one from the healthcare underwriting community.
Thanks, Dom. Yeah, it's interesting. Turning for a moment, and that was a fantastic summary, I think, of the response from the London market, which as we would hope is a measured one. If I could, Mark, just for a moment turn to you. I'm interested in your opinion here. Maybe just turning from Malpractice for a moment and to property. And I know from conversations I've had with you, there's been a lot of discussion here around sort of this test case and the high profile nature of that test case in the UK around coverage under things that are not related to malpractice, but in property. And I know I know you've been doing some work on that. If you wouldn't mind sharing with the audience some of your thoughts on that.
Thanks, Ken. So one of the lines of risk that is particularly concerned in relation to the way that society has responded to the pandemic around the world is the issue of the response of property cover, especially in terms of business interruption, where businesses are effectively shut down due to a declaration of a pandemic and those businesses can't function, so there's no coming in of income. And under the old sort of structure in relation to seeking recovery for loss of those profits, loss of those incomes, people usually claim under their BI policies. And that's certainly where the rubber is hitting the road around the world, and especially in Australia and in England. And the market is full of a lot of conversation at the moment in terms of two very important test cases that are being run, one in Australia and one in England. It is, I think, important to realise that while the test cases are similar, they are fundamentally different. The test case in England, very complex, but essentially looks at the interpretation of insuring clauses in business interruption policies, for example, looking at the definition of denial of access, whereas the Australian test case, which has now been heard but we're still awaiting judgment, focuses more upon wordings in exclusion clauses. And the problem that we're seeing in Australia is that usually cover provided under an insuring clause will be carved back or written back by way of an exclusion which says you won't get losses consequent upon the declaration of a pandemic under the Quarantine Act. Quarantine Act, however, was repealed in 2015 and was effectively replaced by the Biosecurity Act. And the question that is greatly troubling the market is what is the efficacy otherwise of an insuring clause that refers to a piece of legislation that has been repealed and replaced by another? Does it still stand in terms of being the intent of underwriters to exclude cover pursuant to the declaration of a pandemic, or because it refers to repealed legislation, does it simply fall away such that there is no break on losses claimed under insuring clauses? The UK, we've had the decision, quite a complex decision, but effectively found in favour of insureds. A number of appeals going through at the moment. In Australia, we're still awaiting the decision. It's said to be imminent in the next week or so.
Thanks, Mark. Yeah, Dom, just back to you for a moment, and you talked about sort of that steady approach from the malpractice market, which, as we said, fantastic. I'm interested to know, and again, talking about the multitude of countries that you see business come into London from, have you seen any claims from COVID? And I'm talking again specific to malpractice, which is the area that you're looking after. And if you have, just in a minute or so we can move on to some of the other questions coming through. What are you seeing? What are they alleging? What are they for? What do you think? How do you think they might play out?
Sure. Yeah. It's a really interesting question, and I think the answer is definitely yes, but probably not on the scale that the industry was expecting. As I said, early doors, there was some extreme nervousness that healthcare systems were just going to be completely overwhelmed. There was going to be denial of care, rationing, all that stuff, and then the wave of litigation that would follow. But we really haven't seen that many. There's actually a tracker that a US law firm are holding for lodged COVID-19 lawsuits, and we're only just over 100. Some of them do have a class action nature, but to say that the US was this enormous basket case where people are expecting thousands upon thousands of claims to come through, we're just over 100, and we're probably less than 10 from other countries that we've seen lodged against our healthcare policies in London. The majority of the claims that we saw early doors were probably, as most people would expect, they were onward transmission of COVID-19 in the healthcare setting. We had several notifications early on in the pandemic where essentially a healthcare provider was returning from a high-risk territory or overseas or even in the US, unknowingly had COVID-19, was asymptomatic, and then went into the healthcare environment without being adequately quarantined, screened, tested, etc. And there were a handful of cases of Aon clients where there was most definitely onward transmission from that healthcare provider to patients that otherwise just wouldn't have been able to catch it. To give you an example, one was pediatric hospital in Washington, one you're familiar with, actually, Ken. A physician went to a critical care unit that was sort of only had healthcare providers coming in and out for a few days, and there was 7 of the 11 children on that ward ended up with it. No adverse outcomes for any of them, but it was pretty obvious that that's how they'd acquired it. Now, to be honest, I think that period has passed. Everyone is far too aware of COVID now for that type of claim to, I think, really happen anymore. And also, COVID-19 is so much more widespread that other than a sort of a locked down ward that had no one coming or going from it other than a handful of healthcare providers, I think it'd be very difficult to prove that that is absolutely where you got the disease versus early days in the pandemic. I think that's probably more likely. We have had some notification in relation to COVID deaths, which have been lodged, but to be honest, that's more to do with notification provisions on medical malpractice policies rather than the fact there might have been any wrongdoing. Some of them do just stipulate if you have a fatality in your facility, that's a notifiable incident under your policy. Yeah. So clients are just discharging their duty. I guess the big unknown for underwriters is whether there's going to be this wave of COVID-19 litigation coming down the pipe once the virus has died down and sentiment falls away from healthcare providers. I think, thankfully, in a lot of jurisdictions, we've seen pretty robust governmental immunities in place, which should provide a lot of protection for healthcare providers. But there's no doubt it's going to be an issue that's going to take some time to be resolved.
Yeah, it's an interesting segue, actually, Dom. You talk about the sort of, the claims from COVID and the claims arising from, the transmission of COVID and other things. And I've been reading a lot about this concept, Mark, of people sort of rather than contracting COVID, but actually exacerbating other conditions or not seeking treatment because they're actually in lockdown. So the UK last week, again, Victoria, as we know, just coming out of it. And the US has talked about sort of numbers like 41% of adults, not seeking healthcare. And sadly, for people normally with underlying health conditions already and disabilities seem to be that cohort of patients not seeking healthcare for their existing conditions. So the question is, do you see that as being something that will give rise, given that Dom's talked about the number being reasonably small of actual COVID claims, is there another wave coming that's actually claims that result from this sort of failure to seek healthcare for other things because you were following a government advisory to stay in your house?
I think that's certainly worth dwelling on and thinking about. I tend to be of the view that in the current world in which we live, in terms of the government, healthcare providers, public and private facilities attempting to make the best of what is a public health crisis, I sort of see 2 different types of possible exposure. The first exposure is very much similar to what you were just alluding to, Ken, and that is where to simply deal with what can be described as an A&E situation. So try and triage the presentation of COVID cases. There has been what could be described as a button pressed on the rest of the healthcare industry. And what I think is interesting there is that pause button goes across the whole of the life cycle of the presentation of a health issue. So, for example, diagnosis, identification, presentation, treatment, and ultimate recovery. And that's all on hold as far as I can see. If you look at statistics coming out of the UK, it seems to be the case that there's been a decline of 200,000 cancer tests a week in the UK, and a significant drop-off in the referral of cases that are non-urgent within the system. So you tend to reflect upon that and you think, well, if people have had their healthcare put on pause while the system looks after the more urgent cases, could that possibly present itself as a claim in the future? My personal view is I don't think as a general concept it does, and I say that for a variety of reasons. But to my mind, it's analogous to an issue that the health system has always faced, and that's one of resource allocation. The courts must appreciate that the health system in the current climate is simply doing the best that it can with limited resources. And, for example, how can it be negligent per se to decide that the system can only cope with this and not cope with that? Where is the actual indicia of negligence in that regard. But, however, never let a medical negligence plaintiff lawyer let a good crisis go to waste. Where I do see the potential for some possible exposure, and it's interesting to reflect upon what Dom mentioned in passing, and that is one of the things that we've certainly seen in the UK and to a lesser extent here in Australia is the need to man the cannons, as it were. And, for example, in the UK, we've seen significant immediate retraining of specialists. So, for being a urologist, but we now need you to do this. And we also saw the Ministry of Health in the UK, as I understand it, say to final year med students, guess what? You're coming into the hospitals as well. And also we've seen, certainly in this country and in the UK, people in the public health and in the private health system doing incredible hours and making decisions when they may be overwhelmed and incredibly tired, and possibly making decisions outside of the area of their traditional expertise. Now, that's where I see a possible cause for concern in terms of actions against medics and also facilities for allowing that to happen. And I think it's incredibly commendable that certainly in the US and also in the UK, there's been a call for the governments to introduce immunity for people within the medical profession. I think that immunity should seriously be considered by the Parliament. And I also think that it should be an incredibly broad immunity. So not only for, medical practitioners, but also for everyone, midwives, nurses, consultants, ambulance transport. People should think that they are working in a world where they have immunity from suit. I think the only thing I would close by saying, and that is we do have a very robust med-neg plaintiff industry in Australia, usually dominated by a number of key practitioners. If you do go onto the websites of those law firms, a lot of them do talk about class actions in the med-neg space. But interestingly enough, the only example they give is the Ruby Princess and the fact that the Department of Health here in Australia, along with some other government agencies, allowed people to get off the cruiser without sufficiently being tested. So that doesn't really kind of ring in terms of classic medical malpractice or medical negligence. So I kind of find it hard to understand what's going on there, but we all know we do have a very sophisticated class action industry in Australia, and they may try and put something together.
Thanks, Mark. Really interesting. Dom, we heard Mark talk about sort of the UK, some of the statistics there, and I was, again, just sort of doing some of the pre-reading for today, 21,350 positive cases in the UK alone. I think that took you to 160,000 over the last 7 days. And there's been this sort of concept, if you like, that Mark talks about getting people out of med school into their changing specialty, doing this, doing that, with a sense that the NHS might be just overwhelmed by COVID cases, which sort of doesn't appear to have been the case. I'm interested in sort of this concept of the NHS must be protected, and sort of what does that mean? What are you protecting? And also probably as sort of additional to that, does that place an unreasonable expectation then on other sectors, the private sector, for example, to take those patients or to take up the slack whilst the NHS is protected, so to speak? And then what do insurers make of that? From our point of view, what are they saying? This is it's an increase in the risk clearly for private operators. Does it, what does it do, for them from an insurance point of view? We can't hear you, Dom. Sorry.
Might be on mute.
Sorry, you'd have thought I'd got that by now.
No problem.
Yeah,
it's early.
It's an ever increasingly sort of more complex dynamic. Is this whole idea of sort of protecting the NHS, as you say? I think one of the things that COVID-19 has absolutely done, and we've seen this not just in the UK but globally, really, is they brought private and public health systems closer together in places where private health systems sort of do exist. And we've been sort of pondering that, and I think on the whole it's probably a good thing for patients. I mean, certainly in the UK there is a close level of interaction between the NHS and the private system, but it absolutely could be could be better. And I think the way that they've worked together during this crisis will probably provide some very good platform to do better things in the future. But you mentioned that the NHS and the government's their sort of number one priority is to protect it. And what I think that really means is stopping the NHS being overwhelmed in sort of simple terms. And I think the UK did this in a number of ways, and we saw this in other territories as well. But the NHS, they repurposed beds internally, as I know public hospitals did in Australia as well. They cancelled non-elective and non-emergency surgeries, which Mark was referring to earlier. We set up these Nightingale hospitals, which I don't know if you've had any news on, but these were essentially 7 purpose-built COVID-19 hospitals. Now, interestingly, it was a study released 2 days ago that said that each patient that's been treated in one of these Nightingale hospitals has cost over £1 million to treat. And that's simply down to the fact that they just haven't had anywhere near the critical mass of overflow that they thought they might have from the core NHS sort of system. And I just found that really fascinating, that there is absolutely still this drive to we must at all cost protect the NHS, but yet we've got these 7 hospitals with, I think, over 10,000 beds between. They've got the capacity of over 10,000 beds between them, sitting vacant, essentially. So, as I said, this is something that we saw worldwide. This immediate shift to at all costs, we need to make sure that we have the bed capacity, should we need it. And I mean, our experience with dealing with clients is this has just been an extremely difficult period for private providers, as their world has essentially just became very uncertain all of a sudden. We know that private providers, the mainstay of their income is these elective, non-emergency surgeries. So to have them cancelled and the government essentially tell them that they may be pushing patients their way that either they're uncomfortable with or not used to treating, it has been difficult. I know it's been challenging. On top of that, we've seen a lot of governments try and contract away as much liability as they can for any malpractice that might arise in the treatment of those patients. So been a bit of a perfect storm, I think, for the private healthcare providers. And I think on the whole, they've managed it so well. Very, very difficult period. And I understand why governments were trying to do this, but we just saw an enormous range of approaches and some, I think, pretty big burdens put on private health systems around the globe. Just sticking on the UK, the UK was very quick, as Mark said, to offer indemnity to healthcare providers. It's one of the things that we absolutely got right. The government brought in some legislation very quickly, which said that any private provider who assists in the COVID-19 relief effort will be given full immunity, and there were no cardbacks to that. No right backs for gross negligence or anything like that. So that engendered a lot of goodwill in the sort of private world to help with the COVID-19 relief effort. Juxtapose that to the US, where there's the Federal PrEP Act that's in place, but that's more aimed at really sort of drug providers and vaccine manufacturers. There are some states in the US where healthcare providers are operating with zero immunity and zero support from either federal or state government, which I'm just going to imagine the healthcare provider must just be a really, really difficult place to be. You're getting no support. You're kind of operating on your own. You've got these loose guidelines of what you should and shouldn't do with not from the government should things go wrong. Then we had someone like Australia, who I'd say kind of sat in the middle. We didn't see any specific indemnities, sort of frontline indemnities coming forward. But my impression was various states were relatively engaged in the conversation with private providers. And I know at least a couple of them were willing to provide some sort of backstop should a commercial insurance solution be unavailable, which is a lot more than we saw from some other countries. So look, I think sort of as with the main COVID-19 sort of crisis, I said, from medical malpractice standpoint, we've seen them on the whole be relatively supportive. And I think that would kind of be the message that I've seen from governments. I think some definitely haven't done enough to support the private providers and provide some relief from the additional burden, but there's some that have got it really right. So, I mean, I try and look at it in a positive lens, Ken, that I think one of the good things that will come out of this is closer collaboration between the public and private environment. But I think there's no doubt, and I'm sure we've got some private providers on the phone here, that this has been an extremely difficult period for them. Now, just on the insurance side of it, again, the market's been extremely supportive, to be honest. The risk for them hasn't really changed, in my opinion. That's certainly how we've positioned it. We haven't really seen any private healthcare providers be really frontline treating COVID patients, or any patients that are really outside of the norm of what they would have. So there's been no issue to really deal with. For now, it's just more been lining them up in the event that they need to. So no real change for now. If for some reason that changes and the vaccine causes problems and there's additional burden on the private system, I think underwriters will look at that very carefully again. But for now, they're being very supportive.
Yeah. I think one of the things that interests me is, we've spoken a lot about how admirable it has been in terms of government legislature recognising that health providers in these strangest of days need to be kept immune from suit, kept safe from litigation, and I think that that's incredibly laudable. One of the things that we've certainly seen in Australia in the last 5 years is that there is an ever-increasing degree of frequency in terms of medical practitioners finding themselves caught up with the regulator as much as finding themselves involved in civil litigation. And what I think will be interesting to watch in the next 6 months is the reaction of the regulators in this space. And I know that there have been issues in the press reported about procedures being conducted in March and April where, for example, the surgeon took the view that it wasn't elective, that, for example, the screen suggested that if surgery wasn't performed, then the condition may get worse or the infection may get worse. So in their mind, with their clinical judgment, it wasn't elective. And I have heard anecdotal stories of people within the system, people within the surgical team maybe questioning that. But of course, the surgeon saying, no, that's my diagnostic skills at play. That's what I'm going to do. Mm-hmm. And it will be interesting to see whether that degree of leniency and that respect for people doing the best in the most difficult of circumstances will find its way into the regulatory arena as well.
Mm-hmm. Mm-hmm. Thank you both. So, Mark, we've talked about this new normal, and we've talked a lot about the insurance market and other things in the response to COVID. Turning for a moment just to the sort of what the new normal means in the delivery of healthcare, and I think we all, we expect a GP visit to be sitting in the waiting room and going in to see your GP, or for your consultation to be in person, the way we've always done it for hundreds and hundreds of years. But with COVID and with this new normal, we've had to really evolve, and healthcare has had to really evolve the way in which they deliver that. So, we're seeing consultations be by video now, and GP visits, rehabilitation, all those sorts of things to be now just done virtually, as we all have to do now with our work as well. So I'm interested for you to share your thoughts with the audience on what that might mean. So some of the pitfalls, for example, from a legal point of view, does it present a greater compliance regime for people to be able to deliver healthcare in that way?
Yep.
Have you some insights around that?
Yep. So I think it's probably safe to say that it's not new. The concept of telemedicine is not new. It's been around for a not inconsiderable period of time. It certainly was a concept that we were comfortable with before the pandemic. But statistics clearly show, not only in this country, but also, for example, in the UK and the US, that during the time of the pandemic, there has been what could only be described as an explosion in the provision of telemedicine. If you track the insurance statistics, for example, in terms of presentation of cases in the US, at the end of last year, it was floating around about the 20% mark, whereas now latest figures show that in September, about 70% of claims in the US were for the provision of telemedicine services. And certainly if you were to speak to people in Melbourne, they would say that, well, that in many ways was the only way you could see your GP by way of Zoom. So it's here with us. From a legal point of view, however, it's fascinating, absolutely fascinating. And there is no doubt about the fact that in terms of a claim by a patient against a medical practitioner, it's almost always brought in the tort of negligence. There can also be a claim brought in contract. but a claim is usually brought in negligence, saying that there has been a breach of the duty of care that the practitioner owes to the patient. And any good med-neg lawyer, any good med-neg broker will be able to tell you what is meant by the duty of care that a practitioner owes to a patient in the traditional setting, and there's much case law on that. What I find incredibly fascinating is that there is almost no case law on what the scope and content of the duty of care that a practitioner owes in an setting, in a tele setting is. And I know that the federal government has recently done some work in this space in trying to formulate a paradigm for the scope and content of duty and treatment within the e-medicine space, but that I find incredibly fascinating. The other thing too, I think that we should never lose sight of, and that is that while there is no doubt incredible benefit in terms of the provision of e-medicine during times of, say, lockdown when you just can't travel, we never need to lose sight of the fact that that is only a limited answer to the provision of healthcare services. People still need to have liver palpations. Earwax still needs to be drained. People still need to be physically seen and blemishes on skins actually investigated. So there is also a requirement for general practitioners to send people for a physical referral to a specialist. So it is not of and in itself the sole answer. So you still need to be cognizant about, you know, you're going to be for actual physical assessment or physical treatment. And interestingly enough, in an economic assessment done relatively recently by one of the big four accounting firms, they've noted that from a GDP cost analysis, there is more cost to the system, more cost benefit in terms of not GP consultations, but follow-up social work to make sure that people continue to go down the path of wellness. And in fact, one of the things that I think is really quite concerning about what may come out of all of this, and that is just economic interests at play, and how we may see, for example, private enterprise, private equity realising that, to put it in vulgar terms, that there's a quid to be made in this space, and they will be able to provide medical services that would traditionally have been provided by the country or the rural GP cheaper, and that may well start to see an erosion of the role and the necessity and the importance of your traditional suburban rural country GP. And we must never allow just sheer economic return on capital investment erode the essential provision of medical services by people such as GPs, holistic practitioners.
Yeah. That's, I mean, Mark makes a good point, Dominic. I'm sure you'll agree there. It's not new to us. The concept of sort of telehealth and telemedicine is not new. We, and perhaps in the explanation of that, about this sort of the delivery of that and the new normal, it's probably the explosion that we've had to see through necessity rather than sort of being a new thing. So if you could, and I'm conscious that we've got a couple of questions coming through as well, it's sort of on the home-ish stretch. Just for a moment, Dominic, if you could, thinking about sort of the insurance response to that, do they, are they comfortable? As we say, it's always been around. It's probably just had to ramp up in the current environment. And clearly by jurisdiction, that's different. For example, in this state, can I have been able to see our GP, but then in Victoria a week or two ago, you may not have been able to. Is the insurance market comfortable with the concept?
Yeah, I mean, as you say, it's nothing new, but this explosion is, it's absolutely evident. We actually had a very large health system presenting just last week who said that they think that COVID-19 has accelerated their sort of telemedicine journey, and he thinks generally it's accelerated the integration of telemedicine into healthcare by at least 5 years. Probably more like 10 years, which I just found absolutely fascinating, because I think anytime something happens that quickly and it's forced by external factors, there's a scope for increased risk. I think from an insurance perspective, that there's been two sort of insurance worlds that have slowly been on a collision course for some time, and they are cyber and medical malpractice. Now, cyber is a risk that's becoming more and more mainstream and more complex as the world continues on this sort of digitalization journey that it's on. and we've seen it in healthcare with the introduction of the electronic medical record and the issues that presented to the insurance market. But as you say, these digital mediums for care are just being contemplated where they haven't before. Now, in my opinion, that doesn't automatically create additional risk, but it does present additional risk management challenges to healthcare providers. And it's this that insurance underwriters seem to be more focused on rather than the specific sort of problem with it. What they want to know is that the clients are alive to this risk and are proactively managing it. That's sort of the key message. If I think just back a few years ago, the Chief Information Officer role was not one that we saw in many healthcare organizations. And I could sort of list off probably 10 clients who have made a strategic hire in that role just in the last 6 months to now deal with this sort of influx of digitalization in healthcare. And I guess one of the things to think about if you're a client on the line who's thinking about your telemedicine exposure and how you might present it, I think the main message is just to be very, very clear about what services you're providing. And not just that, why do you think it's appropriate to provide them via a digital medium? What risk management framework have you put in place? What's training have staff had if you use an external service provider? What do your contractual terms look like? What due diligence have you done on them to make sure that any product or technology they have is free from glitches or hacks, etc.? It's your opportunity to show that you're proactively really managing what is essentially an emerging risk in healthcare, which we haven't really had for some time. Interestingly, healthcare is by far and away the second most targeted industry outside of financial services for cyber attacks. And I just guess as the use of technology becomes sort of more and more prevalent as we come out the back of COVID-19, so do the opportunities for cyber type events. We haven't to date seen any really large claims as a result of patient harm from cyber, but I think it's only a matter of time.
I'm just conscious we've only got a couple of minutes left, and would be remiss of all of us if we didn't talk about the healthcare heroes at the front line of this, so our nurses and doctors and everyone else involved in that. Mark, I'm hearing your comments around this. Some of the statistics from a recent survey I saw talked about 71% of respondents said that work stress is impacting their life, as you would expect. Yeah. The 50% say they've suffered anxiety, and more than half are doing this work, and in fact much more work than they previously were, for no greater reward in terms of financial reward. So this concept of those workers doing more, being stressed, being anxious, what does that mean in a medical malpractice context? Are we going to see claims where people are now saying, I was exhausted, I've been the double shift, I've been this. What I'm not asking you to necessarily answer the question as to how they can manage that, but what are the resultant effects of that may flow on, do you think?
Yeah, look, I think it's a phenomenally interesting question from a legal jurisprudential and also a philosophical view. I'll be brief, but you may recall that I spoke earlier about the tort of negligence, and that's all very much around the rights of an individual who is injured to commence proceedings against someone else. And you can be injured in a variety of ways. For example, you can fall over on someone's property, or you can fall over in a shopping centre, or you can also be injured due to an adverse incident in a hospital. Within a medical context, there's I think a philosophical greater difference than a public liability property trip and slip, and that is that a patient has put their well-being into the hands of the healthcare provider and relied upon their expertise and their trust. And I think that's one of the reasons why, for example, in countries such as Australia and the UK, we're very loath to erode patients' rights because they're such apposite and specific rights and important rights. But the converse to that is that rights also bear obligations. And on the one hand, while I commend the work that's been done by governments around the world to applaud health practitioners, so, stand on the street and clap, the recent award of Imperial Honours in the UK, people working at the front line, that's fine. That's great that there should be a culture of thanks in society, but I think it should go further than that. There needs to be a philosophical change in legal thinking, and that is simply because something does not go according to patient expectations within the provision of healthcare services does not of itself immediately mean that there has been negligence on the part of the health provider. We need to have at the front of our mind as lawyers, as a society, as a community, that people within the healthcare system in many ways are simply trying to do the best they can. And there needs to be a change in thinking that the moment that I walk into a huge public hospital, nothing will go wrong, because that's not what life is all about. So I commend what the government has done in terms of applauding people and striking coins and giving people medals. But now is the chance to say, let's change the way that we as a society think. It's worked in the past by way of the law allowing for expressions of regret, statements of apology. Let's keep that conversation going.
Fascinating. Well, we're conscious of the time allotted, so thank you very much, firstly, to the audience. Thank you for joining us today. I hope you found this session as fascinating as I did, and to my fellow panellists, Mark and Dominic, we'll let you maybe go back to bed, Dom. But thank you very much. Please complete the survey at the end, and thank you very much for joining us today.
Thanks, everyone.